Vice Rounds is pleased to present Mikey Schaer's Medicine Case Rounds. For those of you who may not have the pleasure of knowing him, Dr. Schaer is a passionate practitioner and veterinary educator who has spent his career meticulously documenting his clinical cases photographically. He has over 85,000 photos from decades of clinical practice and has even published many of them in his textbook. In short, Dr. Schaer is a legend and a wonderful human being. We hope you enjoy these case rounds with Uncle Mikey.
Okay, I hope you're all doing well. We're going to start off with Treat for the Treatable, aka Uncle Mikey's Maxims. And this goes all the way back to the early beginning parts of my career at the Animal Medical Center. And I made certain realizations along the way, somewhat as a result of the building of my bone pile. And keep these maxims around because I promise you that they will have their worth, as will be verified by many of our alumni and other veterinarians across the country. So to start off, I'm going to give you the same lecture I've given at some very large state meetings. A little introduction on Florida, and this happens to be Lake Alice here, pretty area that we all live in. And this is one reason why when I'm running around the lake, I tell people walking their dogs why they shouldn't get too close to the shoreline. And then there's a lot of beauty that goes with it as well. This was out at Paynes Prairie area. And here's the CVM. The building that was up when I first came here is hidden behind the trees. This is building 215, where some of the derm clinics and the ophtho clinics and the pharmacy are in. But all of these flankers here, this is the VAB. These were all subsequent additions over the years in our nice $57 million hospital. And this was taken from the top floor of the parking garage of the VA parking garage. Gives you a nice scope. So the University of Florida, College of Veterinary Medicine. I introduced people to this one. I got here one morning around 6:30, or actually it was before 6 to get this. And I used a special lens filter. This is when the building was just opened. And this is we're going full tilt here, back in around 2012 or so. Okay, so the objectives of this presentation, it's a philosophical approach to emergency medicine. It's going to be very concise. I'm going to show you some more pictures, and hopefully be able to give you many take-home messages. I doubt if I'll be able to get through the whole presentation today, so we'll pick up on it tomorrow. So I've already mentioned that medicine should begin with the patient, continue with the patient, and end with the patient. Words from the wise Sir William Osler, a late 19th century physician. And I basically modeled my career after him. I wish I could have done as much as he did. But he was an amazing man. I'm currently reading his biography by an author called Michael Blaine. It's or Michael Blair. It's absolutely very interesting, super. So early on, I learned that emergency medicine can be fun with a group, but when you're on overnight shift and you're the only veterinarian in a hospital in a city with 8 million people, things can get totally insane. And you just gotta take it as it comes and put yourself in a mindset where it's going to test your ability to cope with stress. It's nice to have colleagues around to help you out though. Above all, do no harm. This is the easy way out. I've seen, unfortunately, too many situations over the years where veterinarians try one thing, or they look at an animal for the first time, the dog or the cat looks real sick, and they right away jump into this option of non-treatable disease. And some animals are going to be euthanized when they do have treatable diseases. And those particular patients might benefit by referral. But I would say back in the 70s and the 80s and even into the 90s, the dead cans were full of animals that might have been salvaged. So don't let this be the cop out, but at the same time, use it as your miracle drug as far as relieving suffering and pain with animals that have non-treatable diseases. Okay, here we go. Treat for the treatable. This is going to be a patient that comes into you while you're on emergency duty. The dog had vomited and it became weak and depressed over the past 24 hours, 24 to 36 hours. And here lies the dog. And the first thing that, of course, you see is that the dog has skin discoloration. And besides that, it is banana yellow. So you recall from our previous discussions that when you see mucous membranes that are banana yellow instead of orange, that means you don't have the red hue from hemoglobin interacting with the bilirubin to give you orange. So whenever you see banana yellow in an animal that gives you this onset of weakness, vomiting, they are probably going to have a deficiency of red blood cells, and a hemolytic disease is going to be immediately in your differential diagnosis. Why do dogs with IMHA vomit? It's probably because the sudden destruction of red blood cells and the effects of hypoxemia on the brain, and it probably stimulates the nausea center. Okay, it's late at night. We have a 34,000 white count, back cell volume of 6.7. We have a regenerative shells made with an MCV of 81. This dog was probably hemolyzing for a few days prior to presentation, even though the history might be within 2 days of presentation. There were some reticulocytes, that's good. The platelet counts at 190 were okay. The dog had a bilirubin of 25. That certainly contributed to that intense yellowness. The albumin was in the low normal range, but the dog was not showing outward signs of blood loss. Liver enzymes are elevated, and why are they increased with the IMHA is because of tissue hypoxia. And that's another reason why you see a leukocytosis in many dogs with IMHA. One of the things I've read in the clinical pathology literature is that the low oxygen level in the central vein of the liver leads to central lobular necrosis, and that contributes to the white blood cell increase. Whereas years ago, we thought that the white count elevation was due to the bone marrow trying to unload all of its cells in response to this fulminating anemia. This dog had a potassium of 2.6. Never really explained that, so that's going to have to be corrected and checked out later on. So in the ideal world, if you could do a big immune panel and get a Coombs and get the IgG and the C3 and all this fancy schmancy immunoglobulin levels, that's all great if it can be done. But I think this basic presentation tells you to look for IMHA or some other cause of acute hemolytic anemia. That could be drugs, infectious diseases, but always remember that common things occur commonly. So you take a drop of blood, you put it on a slide with a drop of saline, and you mix it up, and you see macroagglutination and eureka. This is your midnight Coombs test. So start your treatment, and my advice is this. I've seen some animals admitted overnight with all of the ingredients for this diagnosis, but the steroids weren't given. I don't know why. It could be maybe a fear of giving steroids where someone might be criticized with the service that takes the case, that receives the case. Why did you give steroids before I got my workup, and blah, blah, blah. But in the case of an emergency, students treat for the treatable. And when you have good justification, you don't have to worry about some of these comments that are really unwelcome as far as I'm concerned. So I hope I've explained some of these ClinPath abnormalities. You also know that sometimes they will be concomitantly thrombocytopenic. And when you have autoimmune thrombocytopenia with IMHA, you're going to have Evans syndrome. And that same dog will have urine that looks like port wine. And again, it just screams at you that you have an acute hemolytic situation. So do treat for the treatable and keep your minds open in the meantime. So steroids are definitely on board in the beginning stages of this, and also with a Paxil volume of 6.7, it would behoove you to want to give the dog some Paxils. Okay, treat for the treatable. Another case that comes in. The dog was normal, this little puppy, an hour before. People sat down to dinner, got up, saw the puppy not at their feet in the kitchen. Instead, it was in the living room, just standing still, breathing with elbows abducted and exerted breathing and flared nostrils. And the puppy is brought to you, and you see on physical examination that the respiratory rate is increased and the puppy seems rather distressed. And you do the oral exam and you see this ulceration in the oral mucosa, evidence that the dog had eaten before the crisis, a little bit of food there. And this is classic presentation for an electric cord bite. You don't have to get radiographs at this classic presentation. And the same involves cats, where you want to avoid stressing these animals. Now, if you were to radiograph, and I've made these mistakes in the past, but I also found that the classic radiographic signs will be there by the next morning after the patients get treatment. So here you see the classic caudal dorsal distribution of neurogenic or non-cardiogenic pulmonary edema. It's a fluffy, coalescing, cotton-like infiltrate. We have air bronchograms, and you can see these real well. This is, let's see, here's I-75, and this is Route 441, where you could see all these beautiful air bronchograms. And it's not just caudal dorsal in some of these cases. You could see middle and apical lung lobe involvement as well. And the peracute onset of this is what cues you in. Now, if you compare these radiographs to a dog with acute respiratory distress syndrome, they're pretty similar, although the pathophysiology and the pathology are definitely different, because with ARDS, there is an inflammatory component. But in the neurogenic, non-cardiogenic pulmonary edema that we see with things like electric cord bite or choke, strangulation, you don't have that inflammatory response, and it's not associated with the systemic inflammatory response as ARDS is. So it's all in the history. And you could also see these same radiographic patterns in the epileptic patients who get neurogenic pulmonary edema during the postictal phase of a seizure. So treat for the treatable, good history, good physical examination. Okay, another example of treat for the treatable. This was my own cat. I talked about her before by showing the images, but here she is in real life. Her name was Chloe. She was a real sweetheart, 23 years old. And at this late stage, very late stage, Chloe starts to have urgency to urinate with hematuria. And I was very frightened of the cat having a transitional cell carcinoma. And these were her ultrasounds, and we did a fine needle aspirate, and it was all white cells and bacterial rods, no cancer at all. It was all UTI. So a little bit of Clavamox, and post-treatment check showed that she had done quite nicely. So do try to give them a treatable disease, and treat for the treatable, folks. Treat for the treatable. Okay, maxim number 2. Assumptions lead to trouble, therefore don't assume. This 9-year-old cat presents with decrease in appetite and a little lethargy going on for a few days prior to presentation. Abdominal palpation revealed organomegaly extending from the caudal to the anterior abdomen with imaging showing these loops right here. Very classic uterine enlargement. Here's the colon, here's the bladder, what is between it, the uterus. But the record, when this dog came in, showed that it was spayed at a shelter. And when I told the owner that the cat very likely has a pyometra, because all I could see on the radiographs is a uteromegaly. Now, that could be due to a lot of things like mucometra, hemometra, besides pyometra, and besides pregnancy, but in a young cat like this, that doesn't fit. So sure enough, we went to surgery, and the owner didn't like to have to pay for this surgery, and she was very upset with the first hospital that did the spay. And we kind of put the fire out, politically speaking, by not charging her for this spay. It was just something we thought it would be due to good collegial relations with colleagues. And of course, I picked up the phone and called them, told them what happened, and they were very appreciative of that. So the cat did okay. So verify what's on the record as far as signalment is concerned. And don't forget that pyometras can occur in fairly young animals. It's not always a middle-aged and older age patients. Cats might not necessarily show polydipsia or polyuria. Dogs do, but maybe 50% of your cats will not. So don't forget pyometra. And here you thought that everything was okay, and based on the initial signalment in the record, you assumed that the cat was spayed. But here you go, cat was not spayed. So the owner said, well, why do you think that happened? So I try to give some type of a hypothesis. Well, maybe they started off doing the spay, and then maybe there was an urgency. Maybe the surgeon had chest pains or something, and somebody else had to close up. So that's plausible, I guess. And what else can you say? Okay, you're trained to do cystocentesis, and before the days of ultrasound, I was very confident by moving the bladder with my hand to the lateral abdominal wall, so I had to make sure that I palpated the bladder. And here I show you, luckily I had my camera right not too far from this procedure being done. But this dog came in and she had been PDPU. I thought I was feeling the bladder. We stuck a needle in it and I aspirated pus, and I smack dabbed, ran into a pyometra. So that was very foolhardy. It was humbling. And this was one of those things, I did get away with it. There was no rupture, but it could have been disastrous, absolutely disastrous. So if you ever hear that all cystos are safe, pretty much as long as you're pretty well assured that the needle's going in the right place. Assumptions get you into trouble, therefore don't assume, right? Okay, here's another one, a little kitty cat that comes in, and it was seen to vomit once or twice, not eating for a couple days, and it was vomiting this very awful looking fluid that smelled like feces. And feces with that, vomitus with that description is called feculent vomiting because it's coming from lower bowel. So that's why it smells like it does. And when you look at this cat, now look at his workup. 22,000 white count, mature neutrophilia, PCV 31, nothing to write home about. Radiographs, very remarkable, very remarkable. We had loss of density in the anterior abdomen. We had some displacement of bowel, abnormal dilated loops. The pellet was incidental, by the way. So the pathology was right here in that caudal mid part. And what this was, it was a distal small bowel obstruction caused by the cat eating cellophane. That's probably what we're looking at here on the radiograph. But when you go back at this cat, I mean, this cat did have perforations and the omentum was covering them. And that does not look like a patient coming in with a GI perf. So again, this certainly wiped out my cockiness at this particular stage, which has happened a lot of times over my career. When you think you're out there after 5 years, 10 years, even 20 years, you think you got it. But boy, I'll tell you, don't forget, there's going to be something that day that's going to fool you, or you're going to learn something new with each case. I promise you. Okay, you can't always assume that a female cat with stranguria has cystitis. So we're still on assumptions getting you into trouble, therefore don't assume. So the thing is, if you get a call at 1 in the morning from the emergency service when you're in practice and a client has a female cat that's straining to urinate, many of us are going to assume that it's probably cystitis, it's probably going to be a small bladder, and that it could probably wait till the next morning. But don't be surprised, in some cases, the cat's going to come in and it's going to fool the hell out of you. It's going to have a big bladder. And here we had calculi causing the obstruction in this female cat. So unlike the male animal, where straining to urinate always is a warning sign for a outflow obstruction, we find that many of the female patients will just be straining from urgency from bladder inflammation or a urethritis. But they do get obstructed as well. So the question is the answer is going to be up to you whether or not you get dressed and do that emergency call. Today, things are a lot easier because people can take their pets to emergency hospitals. But after you leave UF, and if you go into a small town and you're the only act in town, then you're going to get that call because there won't be that emergency cover. Another thing I just want to comment on again, calculi today are a lot more common than what they were in the past in these cats with urinary obstruction. And back in the days of struvites, yeah, we had struvite plugs and we did have struvite stones, but in the urethral obstruction males, I have seen a lot more calculi associating with these problems ever since the stone types transitioned from struvite to oxalate over the past 10 to 15 years. Okay, always interpret clinical information within the context of the patient's presentation. So this is maxim number 3. This alcown comes in with a primary complaint of nasal discharge. And it had been, it started off as mucoid, then it got bloody. And the dog came into my medicine clinic where we did our workup. Here we see after the fact, but I'll show you how we got there. Before CT, we had to deal with radiographs. Now, don't think you're not going to be in this type of situation because you don't know where you're going to practice. You might not have all these high-tech imaging. So if you do have to radiograph the skull and you're looking for nasal cavities, make sure you do the open mouth position. Open mouth position. If you do a closed mouth position, there's no way you can interpret detail. So what I see here is a loss of turbinate definition. And that tells me, of course, the dog has pathology. And then I might want to put my ear, my good ear, to the nares and see if I could hear air flowing out, and that the muffled sounds will go along with the animal having some type of obstruction. So then we went on and we did some flushing and we got some cytology. And the cytology was read out as some neoplastic changes, noting that early inflammatory change can be similar. So what are you going to do here? You're going to go back to the owner and say, it's very likely cancer. We're going to go on and recommend radiation treatment and give the dog a guarded prognosis. But I wanted a little bit more than that. We wanted to get biopsies, and I explored the dog anyway. I just wanted to make sure that that it wasn't cancer. And you could see here when we did our surgery, which starts off as a flap inspection into the nasal cavity, and this is a fungal granuloma. This was an aspergilloma. And here they are. Here are your hyphoforms, excuse me. And so what we did for this dog, the surgeons opened it up a little bit more, and then they flushed it out. I forgot exactly what they used. It might have been one of the chlorotrimazole type of products. And then you put them on some long-term ITRA. You don't always have to do that. But this dog came along quite well. And what turned out to, it started out as a possible non-treatable or a minimally treatable disease, turned out to be a more treatable disease. So she did okay. And you could see here that nasal discharge was turning pretty suppurative as well. So always interpret everything within the context of the presentation. And if you haven't ruled out treatable disease, always keep it on the table. Always keep it on the table. Okay, I showed you these variations of acute lymphangitic mammary carcinoma. Those of you who haven't seen it, you know that your usual mammary tumors in the dog are lumpy, bumpy diseases. But when you see inflammatory disease of the mammary glands, and here I show you two varieties of it, and these dogs can also have fevers and high white counts, as this dog did, but this dog did not. And this starts out looking like a acute moist dermatitis. And then when you try treating it with steroids and maybe antibiotics, it doesn't get better. So in a week's time, this thing can double and triple in size. And it's easy to get a sample. A touch prep will show carcinoma cells. An FNA will show carcinoma cells. And it's a bad disease. You cannot get on top of this surgically. I think out of a series of cases that were published out of UK several years ago, I think there was one dog that went on to live for several months post-op. But this is a very bad disease. It's called acute inflammatory or lymphangitic mammary carcinoma. And the other clue on these cases is the fact that either they were spayed late in life or they're not spayed at all. That gives them reason to be predisposed to mammary carcinoma. Okay, here we have a patient where you're going to have to do some more interpretation within the context of the presentation. This cat was referred over for acute onset of not eating and depression. No vomiting was reported. It was seen by local colleagues, found to have an increased temperature. The belly was painful. Cat was very depressed. They saw this cat was going to be a challenge to manage and sent it over to the UF, where the physical findings were exactly as previously described. You see here I'm cheating. There's an exploratory here, right? Okay, so what do we have here? We have a loss of detail in the belly. What all of this density is, this is retroperitoneal fat. So the obese patient will show that. But the pathology is up in here. It's in the mid-abdomen. An abdominal palpation, the bowel did not feel normal to me. It felt like I could feel the small bowel to be adhered. So I suspected inflammatory disease, and then you do your rule outs. What causes inflammatory disease? Perforation, absolutely. Cancer with perforation, absolutely. Ulcer perf, yeah. and one other, acute pancreatitis. But you say the cat didn't vomit. I know, cats don't read the book. And she had a 22,000 white count, 5% bands. PCV was low normal. Fibrinogen elevated, telling you there's a reactive protein, that's a reactive protein, so there's inflammation going on. She may be a diabetic. She might be just transiently stress hyperglycemic. I don't like the creatinine of 2.6. We're going to have to keep a real close eye on that. We didn't have some of the other lipase and tests that we have now, but the amylase was not 5 times normal, so it didn't tell us too much, especially with azotemia. And of course, the potassium had to be addressed as well. So on this particular cat, I was afraid of sepsis, and we lapped her. And what you're looking at is acute pancreatitis. Acute pancreatitis, this is your saponification. Now remember this, if you've never seen this before, if you've never been on a laparotomy, and when you go out and practice, this might be the first time that you're going to look at it, I will tell you this, you will not feel confident in calling this pancreatitis. But after seeing all of these images that I have given you, these will be registered in your occipital cortex, and you will reach back and you will pull it out and say, I've seen this somewhere before. Now, what I was palpating, as far as the small bowel is concerned, these were the adhesed small bowel loops. And why did they occur? Because with acute pancreatitis, you could get peritonitis, but it's sterile. And it almost felt like a pig spiral colon, pig as in P-I-G. You remember from your gross anatomy that they do kind of twist in that spiral manner. But anyway, the surgeons didn't want to do too much dissection here. They don't want to cause any trauma to the small bowel. And this cat did okay, but then went on to deteriorate after it got home, and we did lose her, unfortunately. So what do the surgeons do here? They flush out. They look for any areas of accumulated pus, and they put everything back in. They'll put in a J tube, or today more commonly we'll use an E tube. Avoid tunnel vision. Avoid tunnel vision. That Pekingese I showed you the other day, where she had nephrolithiasis and they missed the pyometra. Maybe we'll talk about her again. Avoid tunnel vision, because the Titanic disaster awaits all of you. I promise you, you are going to fall victim to this more than once in your careers. And I don't care how good you get, it's going to happen. So it's going to require a step back. This is the way I'm thinking now. Is it right? Should I step out of the box and rethink it? So here's that little Pekingese. This dog was seen at another hospital. She was going to be diagnosed as nephrolithiasis and treated for pyelonephritis. Justifiably so. She had a 47,000 white count. She had bands. Her crit was low, that she was inflammatory for a while and sick. Maybe she had SIRS as well. The glucose was 40, so she had sepsis. So she had urosepsis in the setting of an increased BON, a creatinine that's elevated, just a very, very sick dog. The urinalysis was opalescent, cloudy urine, definitely due to pyuria. She definitely had a pyelonephritis, but she also had the pyometra. This was missed. This was missed. She was treated at St. Elsewhere with antibiotics for around 5 to 6 days. And finally, when they saw the dog was going south, she was referred. And what we had to do first is take the pio out. The stones weren't touched because that wasn't the immediate threat to her life. Surgeons had a very, very brittle patient. And to bring this one to closure, she passed away as well. But I would have said earlier that she would have had a treatable disease. So that's why time is of the essence. And we never want to let the sun set on a pyometra. Remember that. In a sick pyometra, it's even more important. If they come and walk in, not vomiting, looking pretty good, they could probably wait till the next day. But this dog required the fast track to surgery. Treat your patient, not just its disease. This is another one of those disciplinary things where you're going to see a dog or a cat or a horse or a cow, and they're going to have outward features of an obvious problem that you're going to focus on, look at with tunnel vision, and forget the rest of the patient. This particular dog got hit by a car. She came in laterally recumbent. She had rotational nystagmus. She was very much stuporous. She was tachypnic, and everything's were pointing neuro. I still get chest and abdominal radiographs on my trauma patients. I have just missed too much over the years. And sure enough, she had a pneumothorax from hell that required immediate care on top of the traumatic brain injury. The latter would have gotten mannitol or 0.9 saline. Today, 0.9 saline, I think is not 0.9, hypertonic saline. I'm sorry, I did not mean to say 0.9. Hypertonic saline for the traumatic brain injury. And another thing I don't want you to forget is this. This is day one. This patient can come in with a normal sinus rhythm, but do remember to take the patient out of the cage every day and examine it. I have seen practitioners do their rounds by just walking by the cage and letting the technicians do all of the handling with the treatments, et cetera, et cetera. I've watched this happen, and I see it happen. But I swear to you, never one day in my life did I ever not take the patient out of its cage once or twice a day and examine it myself because they change. And here on day two, the dog had a blatant ventricular tachycardia due to the so-called brain cardiac syndrome that is known to occur in trauma cases. And we do see this. So although it wasn't there on day one, you want to make sure that you're on top of it on day two. Okay, getting into maxim 6, avoid over-medicating. A cat straining to urinate, a male. He came in with urethral obstruction. We unblocked him. We did put in an IV catheter. The fluid rate was set. I went out to the clinic, came back and checked the cat around 30 minutes later, and it was initially treated with a 500 ml bottle of LRS, and I saw that the cat was dyspneic at that recheck point around 30 to 45 minutes later when I came back in from the clinic area, and the cat had a pleural effusion. And why was I suspicious for that? I looked at the bottle and it was totally empty. There was no more fluid left. So the whole bottle went in too fast. So this is where I caution you about bolusing animals. And think about it. I just want you to understand this. If you have a cat that comes in and it's hyperkalemic and it is myocardiotoxic, we might give one bolus of fluid, okay, 7 to 10 ml per kilo, good, okay, we're not going to worry about that. But if you were to keep on blasting away, that heart is not normal. That heart is myocardiotoxic, and you might put that cat into fluid overload. So be careful of that. So what I used to do is estimate the dehydration deficit, calculate the total maintenance, which is going to be 60 ml per kilo, plus the dehydration deficit. That's what the first 24 hours is usually going to amount to. But instead of bolusing, what I would do is I would give 1/2 of the dehydration fluid deficit over the first hour or two, and then the remaining amount of fluid in 24 hours. And I see the bolusing to be valuable when you really need it for a markedly hypotensive situation. But be careful if they are not that hypotensive. So this was strictly iatrogenic. Now what you're looking at here is an adult IV delivery apparatus that will equal, let me see, this is around 16 drops per ml. But then there are pediatric varieties whereby it takes 60 drops to equal 1 ml, which are a lot safer if you don't have these IV infusion pumps. Oh, and another thing I want to tell you, when you go into private practice, a lot of practices can't afford to have IV infusion pumps on every case. They might have a couple, they might have none. And as a result of that, you're going to want to think about having some pediatric IV delivery devices that will help avoid fluid overload. So in this case, what had happened was this. When the jugular catheter was put into this cat and the fluid rate was set, unbeknown to the technician, there was a kink in the catheter that we were able to later discover because we had exteriorized part of the jugular catheter on the lateral side of the neck when the catheter was too long. And so when we examined the system, we saw that kink, and what had happened, the kink was present when the fluid rate was set, and then when the cat got into the cage, the neck moved, the kink reduced itself, and the IV fluid load went into the cat. Okay, another thing about overtreatment is dealing with obstipation. Forget fleet enemas altogether in small animals, especially if they're obstipated, or you'll get a beautiful case of hypocalcemia, as I show you here with this cat seizuring from hypocalcemia following a fleet enema that was given a couple hours before this emergency visit. And the calcium at that time measured 5 milligram per DL, phosphorus over 20, and the sodium was 174 because the fleet enema also has a large amount of sodium in it as well. So at this point in time, you're going to reduce your fluids to something like half strain saline or 0.45%, or half strength lactated ringers, or half strength Normasol. And the reason that the calcium came down is because of the high phosphate going into the rectum colon area and not being able to evacuate because of the obstipation. So it followed an osmotic gradient, got absorbed into the bloodstream, met up with calcium, and said, hey, let's get together. So they precipitated, and you get acute hypocalcemia. So anyway, so here this cat was 30 minutes prior to presentation. So it does occur quickly. And I've created this in a dog as well. So do I use fleet enemas? Yeah, if I'm cleaning out a giant breed for a lower bowel study, I would do it not having to worry. But anything less than 20 pounds, I worry. Avoid overtreatment. This is a dog that was treated with steroids for a long period of time. You might have seen him before. It was a derm case. And you're looking at diffuse calcinosis cutis, both the inflammatory form and the dry form, where he had been treated with prednisone for an allergy that was not confirmed and never diagnosed. So the steroids had to be tapered. And he was treated with hydrotherapy, and it took several weeks of nice, gentle management of the skin, and it did get better. Calcinosis cutis will usually go away over a period of time, and that's going to take sometimes a couple months to a few months. He did do okay, though. This was a Cushing dog of my creation. This is Lassie Lester. I showed her, I think, during one of my, during the Cushing lecture. And she came in for what came out to be an eosinophilic pulmonary granuloma. She had diffuse granulomata in the lungs. And this was an AMC case. And this was Lady Berger. And Lady also had some pyoderma as well. So eventually, after not making any headway with some low-dose steroids, I wanted to get a tissue diagnosis. So we did a thoracotomy, confirmed it on histopath, and then I blasted her with steroids, which did cause remission in her lung problem. But look what happened. On 6 months of steroids, I made her very, very Cushingnoid, and you could see how truncal she is in her weight gain. The Demodex went bonkers. She had a hygroma on the elbow because of the way that tissue gets thin, and she was laying down a lot. So we had a lot of iatrogenesis here, but the reward for it all was the fact that she could breathe. That was the trade-off. So finally, after 6 months of steroids, and after the owner almost virtually got rid of everything in her house for fear that there was something causing sensitization, and the dog did not have heartworms, and I don't know if we ever really nailed it down to the exact allergen, but we were able to taper her down, and here she is, having gotten much better, and she cured and eventually went off of steroids. But sometimes that over-treatment is important, like you will see with some of your IMHA and ITP cases, or inflammatory bowel disease, or whatever, other conditions that need long-term steroids. And there is a price that you pay. So discuss this with the owner and say you'll do what you can to help avoid the problem. Students, be honest with yourself. Be honest with yourself. You're not going to have me over your shoulder, harping on you, reminding you to do this, to do that, to think of this, to think of that. And that poodle I showed you that sat in a hospital for 5 days of vomiting, that had GI perforation. This is what the dog looked like when she came in. She was a disaster. She was being treated for gastritis. And then she finally was referred after 5 days at St. Elsewhere. And she had a very, very abnormal linear form body type of pattern with loss of abdominal detail, free bacteria on abdominal tap, toxic segs. This dog had to be triaged and in the surgery. Believe it or not, we got her in there like in an hour and a half. I mean, she was on the verge going in, and she died. And she died. So behold the truth. Behold the truth. The necropsy will be that judge and jury. And this shows you the dog having ingested pantyhose and having multiple obstructions that perfed, and it was a disaster. And I spent a lot of time in the necropsy room. This was Dr. Farouk Zaki and Dr. Potnick. Remember the Potnick classification for mast cell disease? This is Amaya Potnick. He wrote that paper and became famous because of it. But never let the sun set on a linear form body obstruction, because they will only get worse. And you could see there was a price to pay for that one. Very sad. Don't postpone today's urgencies till tomorrow. I guess that linear obstruction is another example. But here you see a little Maltese puppy. It was purchased at a pet store a few days prior, had some loose stools that got worse, and the appetite diminished for more than 24 hours with no food intake at all. And it came in like a little wet noodle, hypothermic, and you better think hypoglycemia. Don't forget that. Now, go ahead and you want to measure that, but don't forget that this is a classic presentation, because these pediatric patients might not have enough maturity in their gluconeogenic reserve in the liver, and they might not have a substantial amount of glycogen to cover their interprandial period. So however you're going to measure the blood glucose, you're going to find it low, and you're going to get your 50% dextrose. Remember that emergency dose at 1 ml per kilo IV push. Just make sure that that needle is in the vein. Make sure it's in the vein. Now, if you use 5% dextrose solution, it's not going to work right away. You need concentrated dextrose solution. And then sometimes even then, you'll have to wait around 20, 30 minutes until the brain gets its act together following the insult caused by the hypoglycemia. So we could say treat for the treatable, timing is of the essence, don't delay today's emergencies. And the other situation, I just want to tell you that a lot of these cases have stories. This might be a patient who comes into your clinic at the very end of the day. You want to get out because you got a date or you have some big family plans, and you don't have a big scheduled time to do a workup on this puppy. And there might not be an emergency clinic because you live somewhere in who knows where, and you're the only act in town, and maybe this workup will just have to wait until tomorrow. It's not going to work that way. It's not going to work. You can't postpone a starving brain. It's going to get very mad at you. So, because ultimately the pathology will be a pseudolaminar necrosis, and you don't want that to occur. Okay, here we are. You've seen a zillion of these. So the cat comes in, it's a urinary outflow obstruction. The cat's obstructed, but after the first 50 or ml of urine, the cat stopped making urine. That's not good. That's not good, especially while the catheter's in place. So here urine had been coming out, and now the line is empty. And the cat is showing you all of the signs of hyperkalemic myocardiotoxicity. So this is going to require the hyperkalemic cocktail, right? Calcium gluconate, insulin dextrose, terbutaline, bicarbonate, you're there. But you know what happened with this cat? It had such a severe hemorrhagic cystitis, the ureteral openings were closed. And the cat became anuric because of that. The cat did go to necropsy, and that's where I made that diagnosis. Don't postpone today's emergencies till tomorrow. Classic thiamine deficiency. I'm probably the only clinician that you've heard talk about thiamine deficiency. So I'm sorry if I bored you, but don't forget it. And repetition will make you remember this. So this particular cat came in, it's an apartment cat, fed a commercial cat food diet. Everything's fine. And then suddenly the cat starts to slow down, and over the next few days, it becomes ataxic and wobbly, and then it becomes demented, where it looked to me like it had an injection of ketamine. And this is the way a cat with thiamine deficiency looks. And then the cat even was cooperative enough to have a thiamine deficiency. So I've mimicked these seizures to some of the students in the past, but they're very quick, and it's a body flexion. So it's not like a drooped neck from a hypokalemic cat. This is like a ventral cervical seizure. All right, I'll imitate it again. Watch. Okay, don't laugh at me. Here we go. And that was your cat. And I suspected thiamine. Why? Because I had read about it and I pulled it out of my black bag. You can measure the blood level, but you're going to wait a week or so to get it back. Better yet, just give the thiamine, hydrochloride. Give 50 to 100 milligrams IM or sub-Q. Do not give any B vitamin by IV push. They're all anaphylactogenic, as is vitamin K. Never by IV push. What you expect to see is a 50% improvement by the next day. And then you'll change the diet and give them the thiamine supplementation, 25 to 50 milligrams a day by tablet for around a month or so, and they will do okay. They will do okay. And you don't want them to get permanent pathology, which would be a polioencephalomalacia, just pathologically speaking. Some of the large animals could get these as well. Thiamine deficiency, treatable disease. Treat for the treatable. Don't postpone today's urgencies till tomorrow. All these maxims playing out right in front of you. So there's the thiamine hydrochloride, and even Garfield can get thiamine deficiency. Now, why would a cat get thiamine deficiency in a balanced diet, with a balanced diet? Because thiamine is a heat labile vitamin. And at the food company, they do add the thiamine to the food, then they heat process the food. Then they can the food. Then they store the food. Then they transport the food. Then it's stored again. And if it is in a hot environment, you could see how a heat labile vitamin might be dissipated by the time it gets into the cat. So this does happen. It's rare, but if you don't think it, so help me, you won't find it. So think the common things occur commonly. We'll do a couple more images here. Here's a cat. What's this cat telling you? Why does he like to hang around the oxygen inflow port? Right. So he comes in as a respiratory emergency. This cat in particular was not a coughing cat. It blew my mind when I found out what was wrong with it. But he had an acute onset of dyspnea. And this was an indoor cat. So we ruled out the usual causes of trauma, infection, da-da-da-da-da-da-da-da-da. And it came down to a radiograph on this cat. And there it was. There was the diagnosis. We had lots of donuts. We had Dunkin' Donuts. We had a chocolate glazed here and little strawberry. And the cat had a hypersensitivity lung disease or feline bronchial asthma. And it even had a mucus plug causing some atelectasis of that middle lung lobe. So this was classic. But guess what? This cat should have had a history of coughing. And this was only one of 2 cats who did not have that history. Now, maybe the owner missed it, and I think the owner missed it, because when you have a bronchial insult, the afferent receptors for the cough reflex are in the bronchi and the trachea. And that's why it's kind of hard for me to believe that the cat was not coughing. So anyway, treating for the treatable, right? Common things occur commonly. So you got that dyspneic cat that comes in at night, fairly acute onset. Once you rule out trauma, then you're going to think of lung disease or cardiomyopathy. You're going to do imaging carefully, not to stress the patient, and to give you a reason to give them the silver bullet. So steroids would be in order. Another thing, thinking that common things occur commonly, a heartworm treated dog. This is when we use the drug called caparsolate, and we expected worm emboli to begin anytime from day 2 to day 21 after the adulticide treatment. And here we have a dog who a week after treatment came in with hemoptysis and dyspnea. The radiographs were humongous, showed pulmonary emboli, beaucoup. And that dog died, unfortunately. But when you see the amount of pathology between the worms being present and the intimal proliferation And the inflammation, it's no surprise that some of these patients will succumb. Okay, I'm going to stop here. And are there any questions? Okay, no questions. Tomorrow we will resume with Treat for the Treatable. And we should be able to finish it up. And from now till then, have a great day, be safe, and please take care. Bye-bye.
Thank you.
Thank you.
You're welcome, guys.
Thanks again for tuning in. We hope you enjoyed these digital case rounds with Dr. Michael Schaer, and we hope everyone is staying safe out there. We'd like to extend a huge thank you to Dr. Michael Schaer for allowing us to share these rounds on the Vice Rounds platform and with you students all over the world.